Hello, can you hear me? Perfect. Sorry, tell me if you can hear me. It's a delight to be with you today. It's wonderful to have this large audience. This program has been sold out within 24 hours, which is a new record for us. And the topic that we're going to be talking about today is near and dear to my heart. So it's a pleasure. Let me walk you through the objectives first, and basically if you can give me the slide with the objectives for today's program. The learning objectives, we're going to first start talking about why Hispanics and Latinos, and today we use both terms as is the same term, are disproportionately impacted by COVID-19. What are the reasons? What are the realities that influence this at an individual level and at a systemic level? And what other factors make the Latino community, the Hispanic community, more vulnerable to COVID-19? We also want to talk about individual factors that play a key role when our communities are having to discuss advanced care planning. And we're going to talk about ways and hopefully provide you with some tools to enhance these discussions with Latinos and Latinas. We have two wonderful presenters today. The first half of our presentation will be done by Dr. Olivia Carter-Pokras, and I'm going to first introduce her, and when we move to the dialogue with Dr. Maria Izquierdo, I'm going to introduce her professional credentials at that point. So first, let me introduce Dr. Olivia Carter-Pokras. She's a professor of epidemiology at the University of Maryland School of Public Health. She's a healthcare disparities researcher for 4 decades. Dr. Olivia Carter-Pokras has been recognized by the Governor of Maryland, by the Surgeon General, by the Assistant Secretary of Health, among other major personalities, for her career achievements to improve racial, ethnic data, because she's worked very hard to develop health policies to address health disparities and improve healthcare for Latinos. Among many projects she's been involved with, she has led an NIH-funded research project to develop cultural competency and health literacy curriculum, and has served as co-investigator for a European Commission-funded project to develop cultural diversity and training for health professionals and educators. So she's not only well-known nationally, but she's also internationally well-recognized. She has partnered with governments, community-based organizations. She has published 74 peer-reviewed journal articles and has been cited over 5,100 times. Her research has played a critical role in national recognition for health disparities for Latinos. Dr. Olivia Carter-Pokras, it is a great pleasure to have you with us today. I'm going to turn the mic to her.
Thank you very much, and welcome everyone. Thank you for taking time to join us today so we can focus on what some of the issues are in regards to Latinos, Hispanics, and COVID-19. That's the pandemic that we're on right now, and I'd like to congratulate all of you and thank all of you who are out there working so hard. We all are trying to work during a crisis. So not only are we going to be talking about issues that are affecting the communities that we're serving, but we're also going to be talking about suggestions that you can do to protect yourselves as well as to support others in your family and your friends. So let me see if I can move the slide forward. If not, hopefully Bizak can help me with this. Nope, that didn't work. There we are. Thank you so much. So you have seen in the news when we're talking about racial ethnic minorities are disproportionately impacted by this pandemic. This is just from the last few days. Everywhere from New York City, Hispanic community in New York City disproportionately impacted by COVID-19, to Twin Cities and Minnesota talking about coronavirus mirroring other health inequalities impacting Minnesota's Black and Hispanic residents disproportionately. Even Oregon, new data show Latinos in Oregon are still disproportionately affected by COVID-19. And California, like Santa Barbara's counties, Hispanic population hardest hit by COVID-19. So is that the case here? And we'll take a closer look at it. Use the next one, please. So here in the Maryland, DC area, we don't have, unfortunately, data by race ethnicity for the state of Virginia. They do have for African Americans, but they don't have data yet for Hispanic ethnicity, but we do for the District of Columbia and for Maryland, and limited data for the United States. And what it does show is indeed we do see a disproportionate impact. In fact, in the DC metro area, we see even a greater disproportionate impact for Latinos than we do in comparison to the United States. Within the District of Columbia, 24%, or essentially 1 out of 4 people who have been currently impacted by COVID-19 are Latinos. And in Maryland, it's about 1 out of 5, and that is rapidly increasing. Next, please. So why is that the case? Well, for one thing, a large proportion of our Latino community are immigrants, and we know that immigrant workers are disproportionately vulnerable. They pose a significant share of workers who are cleaning hospital rooms, staffing our grocery stores, producing and transporting food across the country. They are considered essential workers right now. They're also overrepresented in sectors that are suffering mass layoffs, for instance, restaurants and hotels, cleaning services for now shuttered office buildings. And those in the hardest hit industries tend to have lower incomes than their US born peers and are more likely to lack health insurance and or have a minor child at home. Another example is they don't have sick leave, or if they do have sick leave, it's not paid sick leave. So as you can see, there are many different reasons why they're disproportionately vulnerable in terms of the types of jobs that they have. And you can see how this impacts in terms of overall socioeconomic status with the lengthy lines that occurred just a week ago, waiting lines at Megamart to get the free food that was issued in Tacoma Park. Next, please. So within the state of Maryland, we see that Latinos are less likely to have health insurance. It's not just here in Maryland, it's here across the United States. And those who are disproportionately impacted are particularly those who are foreign-born. In fact, 1 out of 2 foreign-born Latinos in the state of Maryland do not have health insurance. Ability to pay being the biggest barrier in terms of access to care. Next, please. We also see this in terms of the impact on poverty. Latinos and African Americans are more likely to live in poverty. These are data from the state of Maryland. And you can see among those who are working age, ages 18 to 64, 13% of Latinos are living in poverty. That means below the official federal poverty line. And among African Americans, the same percentage. Next, please. We also see that we have households that are living in close quarters with multi-generations. The average household size is larger, 3.87 persons, for Maryland Latinos and Salvadorians in particular, 4.9, than the state overall average of 2.6. They're more likely to live in apartments, and these 2 photographs are from an article that was published by the Washington Post talking about the disproportionate impact of COVID-19 in the Latino community, particularly in Langley Park. Children often live in households with adults and the elderly, and so there might be multiple generations in one household or less opportunities for social distancing. This past week, the Centers for Disease Control and Prevention issued guidance in regards to what to do if you do live in close quarters. But unfortunately, in discussing these recommendations with colleagues who are definitely on the front line, who are directing the community health centers and providing care to those who are suffering right now from COVID-19, they agree with me that these recommendations do not reflect reality. They're basically telling people to stay the physical distancing of 6 feet or longer, not have the elderly take care of younger kids, but then it raises questions. Well, if the elderly are not able to contribute by taking care of kids, it loses their sense of purpose, A, and B, who else is going to take care of the kids when the parents have to go and work or go out shopping or whatever else that they have to do? So it doesn't really reflect reality. So what are some of the things that you can do? Yesterday, Dr. Donald Milton from the University of Maryland School of Public Health, in a different webinar, he made a suggestion that individuals who are providing care or perhaps exposed to others with COVID infection, that when they come home, they may decide to continue wearing masks. He also pointed out the importance of opening windows because he felt that improving the air circulation would be very helpful. And it's important to stress the need to be creative and coming up with solutions about how you can support your staff as well as how can you support your clients. For instance, my son-in-law came up with a great solution because he was told by his management at the nursing home that he runs that they could not approve the increased pay for hazard pay for his staff who were coming in and interacting with the nursing home residents. But what he was able to do with his existing budget, he was able to reconfigure the budget and establish a food pantry in a separate room where he was able to stock with chicken and other foodstuffs. And so the staff could come in and get essentially free food. He couldn't pay them extra money, but he was able to provide this food pantry. So being creative is going to be very important, and also making sure that you have opportunities to talk about what can be done to support in socioeconomic status individuals who are hard hit by this pandemic. And I wanted to mention our county government has just made a decision to help support individuals in this situation. And so somebody who is infected by the virus who lives in these multi-generational households, they may be able to obtain permission to have their housing paid at a hotel. So that's certainly something to look into, whether an option like that is available. Next, please. So these health disparities that we've identified, these disparities in access to care are not new. Neither are the recommendations on how to address them. For instance, in 1993, the Surgeon General at that time, Tony Novello, coordinated multiple meetings, and we came up with this report, the Surgeon General's National Hispanic Latino Health Initiative, both. In 1985, the report of the Secretary's Task Force on Black and Minority Health also came out with recommendations. So these have been around literally for decades. One of them is that we need to address universal access to healthcare. We need to improve our infrastructure for providing healthcare, and we need to enlarge the pool of Hispanic Latino health professionals to provide culturally competent care. So hopefully, if something beneficial comes out of the pandemic, maybe it's getting that social support so we can make these changes happen. Next, please. So what are the health priorities for Maryland Latinos? For many years, they focused on access to care, language barriers, and low socioeconomic status. These issues have not gone away. They've only just been brought to light for many with the pandemic, and the interrelatedness of health issues to other health problems, such as employment and stress. When we conducted in-person surveys, we found that our telephone-based surveys really were not accurate, that actually many more Latino adults were lacking health insurance. And that it's a false premise to say that Latinos are overutilizing emergency departments. In fact, we find an underuse of emergency departments. And an overall recommendation for use of medical interpretation, U.S. healthcare system workshops about how to navigate the U.S. healthcare system, licensure of foreign trained nurses, and outreach clinics. Next, please. So what are the subgroups at high risk for severe illness from COVID-19? From the Centers for Disease Control Prevention, they say those 65 years of age or older who live in a nursing home or long-term care facility have an underlying medical condition, particularly if not well controlled. Now, you noticed I have highlighted in yellow several of these because these are issues in which Latinos and African Americans are disproportionately impacted. Having moderate to severe asthma, having HIV, having diabetes, having liver disease. Next, please. Okay, I think we flipped through one, but I did want to point out these underlying conditions are really of a concern. Asthma is one of the issues where you can see I've highlighted with a blue arrow Puerto Ricans, because many people do not realize African Americans and Puerto Ricans have the highest rates of asthma. This is not something that's new. It's something that we've known since the early 1980s, if that's indeed the case. Next, please. In regards to new HIV diagnoses, among the most impacted populations are African Americans and Latinos. Males, as you can see, the two highest bars that are showing up on this graph from the Centers for Disease Control and Prevention. Next, please. And the prevalence of severe obesity is really a concern right now. In the United States, our rates of overweight and obesity are higher than in some other countries, and we also see these high rates even among children. The prevalence of severe obesity among 5 to 14-year-old students in New York City, when they did this examination, this was published by the Centers for Disease Control and Prevention, you see that the groups that are at the highest rates are African Americans and Hispanics. And indeed, this might partly explain why we have seen such a high proportion of the kids who have come in with coronavirus at Children's Hospital. This was a news report that just came up this weekend that noted that a high proportion of the kids ended up requiring hospitalization. And they noted that if a child with an underlying condition like a cardiac condition, obesity, asthma, any chronic medical condition, this could lead to hospitalization or critical care admission. So we have an underlying group within our community that is our disproportionate risk in terms of severe complications from this pandemic. Next, please. Also, Latinos and African Americans are more likely to have diabetes. Nationwide, 12.1% of non-Hispanic whites compared to 20.4% of non-Hispanic Blacks, 22.1% of Hispanics, and 19.1% of non-Hispanic Asians have diabetes. Now, among Latinos, that prevalence varies by subgroup. It's highest for Mexican Americans and for Puerto Ricans and for Cubans. But even for Central Americans, which is the largest subgroup in our area, that's still 1 out of 5 Latina adults has diabetes. Next, please. In regards to chronic liver disease and cirrhosis, Latinos are also more likely to die of chronic liver disease. Known risk factors for this include hepatitis B or C infection, heavy or binge drinking, obesity, diabetes, and metabolic syndrome. Next, please. These underlying conditions are less likely to be well controlled among racial ethnic minorities. We notice that high blood pressure control is low for everybody, not just for Latinos, not just for African Americans, but it's even lower among these subgroups. Among those who have been recommended to take blood pressure medication, in other words, they're aware that they have high blood pressure, right? They've gone for treatment, they've received this recommendation, but then that next step, blood pressure control, among those recommended to take blood pressure medication, that blood pressure control is lower for African Americans, only 1 out of 4, non-Hispanic Asian adults, 19%, or Latinos, 25% than non-Hispanic whites. Type 2 diabetes also has shown consistently worse glycemic control for various markers, various indicators. And asthma, more likely to have uncontrolled or severe asthma. For HIV, they're also more likely to be unaware that they have this condition. 1 out of 6 Hispanics and 1 out of 7 African Americans with HIV are unaware that they have it. Next, please. So years ago, John Eisenberg, who at that time was the director of the Agency for Healthcare Research and Quality in the federal government, came up with this model called voltage drops to explain what is important in terms of quality of healthcare. They said the first thing is to make sure everybody has health insurance, okay? Then the next thing we need to address is not only that it's available to them, but that they are enrolled in the insurance. The next step is to make sure that the providers and services that are needed are covered. And then the next one is that giving patients a choice. So they have a choice of what they would like to receive. The next step is having a consistent source of primary care available. And then following referral services are accessible. And ultimately, all of that is important in terms of high quality care. So what's happening in terms of access to testing, access to treatment, in terms of these various steps that are important in terms of healthcare quality? Well, we're having barriers such as transportation, interpretation, literacy, hours available, etc. All of those are coming into play, okay? The picture that I have here, right above where it says quality of received care, is the photograph of where you can go to obtain testing in Montgomery County and have it covered. It is up Route 29 in White Oak. That's where you have to go for care. So somebody who lives in Gaithersburg or Germantown, this may be a challenge for them to get the transportation to come down to get that. Also, there were a lot of concerns about not having sufficient access to information about where to go for care. And then finding out that not only do you have to get yourself there, but you have to have a referral. And to get a referral, you need to have a referral by your primary care provider. Some of our primary care providers, because they just were overwhelmed, they couldn't figure out how to handle the personal protective equipment, etc., they shut their doors, and so they were not taking patients, or they were refusing to virtual appointments. Luckily, our community health centers have really stepped in, and so they made themselves available not only to those who don't have health insurance, but as well as those who do have health insurance who are also having difficulty in getting access to the referrals for testing. So once you get tested, then there's the concern, if you test positive, then what happens? What's going to happen? Is your employer going to allow you to continue to work? How are you going to bring in money? In addition to that, there's the concern about getting the care that you need, and what do you do with that positive test result? So these are all things that are in mind, and our county government has really been working hard trying to address it at multiple levels. Next, please. So one of the reminders that I'd like to give at this time is that there are standards. There is guidance in what we should be doing in terms of improving access and quality of care. One of these standards is the National Cultural and Linguistically Appropriate Service Standards. They came out in 2001 and has since been updated and revised. And important notes for that is that it is aimed at providing effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. You may not be aware, but the state of Maryland actually has a legal requirement that says that government agencies should be provided services in the language that communities that have at least 4% or greater of the population in speaking that language. So that means that we need to make sure within the state of Maryland that we're providing information available in Spanish, because more than 4% of the population in Maryland has met that requirement. Next, please. So unfortunately, there's been pushback by many over the years in providing the medical interpretation, translating documents, etc. And this resistance takes many forms. One is that people are saying they're not paid to do this. It's an unfunded mandate, that their higher priorities, our system lacks the basic services, and that's what we really should be focusing on. Or they may say these requirements are prescriptive and administratively burdensome, so they can't figure out how to do this administratively. They say this is special treatment for a small group of people. These standards exceed current service standards, or they say our services are available to everyone. So we've taken care of it. Everybody has access, whether they understand how to access it or how to navigate the system or understand your medical recommendations. That's another question. And how do we operationalize it? A lot of questions about it. So just be aware that this is some of the pushback that has been going on, not now, but literally for years, and pushing back in terms of providing information in the language that is needed for people to understand what they need to do. Next, please. Unfortunately, there's a negative result if we don't sufficiently prepare, if we don't provide medical interpretation, if we don't provide translated documents. As you can see, what happened a few years ago, this was from an article that was published in February of 2017 after a fire took place in Langley Park, and several families all of a sudden found themselves out with nowhere to go and all of their belongings gone. when the investigation was done later on about how we can do better in terms of addressing emergencies, this is some key language that came out of that report. There were challenges with some of the residents getting sufficient information about aid and assistance and help that was available to them. They also mentioned the lack of Spanish-speaking staff at the shelter, at the scene of disaster, and when survivors were seeking information about shelter and other help. Next, please. Several years ago, after 9/11, working together with Montgomery County government with funds that came through the Centers for Disease Control and Prevention to address emergencies, and particularly they had in that mind terrorism, but we also, our communities have also been impacted by the shooters. I don't know, those of you who live in Montgomery County, you may have remembered the snipers that were taking place. But what surprised us, we thought those were the topics that they might have had in their mind, that community members might have had in their mind when we asked them about what is an emergency. What we heard back at that time was that immigration was top on their mind in terms of emergency for the community. Unfortunately, here, more than a decade later, we're still in that same pickle. And what we're hearing is exactly what we heard back years ago. We're frightened because we don't know what's going to happen with immigration. This is an emergency. Some people don't even want to go out of their house. We're hearing from medical directors that patients with COVID are afraid to come in for care because they're afraid that this is going to negatively impact on their attempt to get a green card. And just look at what's happening in the news. In the news during the past week, from NPR, White House seeks to lower farm worker pay to help agriculture industry. The New York Times, Trump halts new green cards but backs off broader immigration ban. From the Washington Post, to suspend immigration to U.S. for 60 days, citing coronavirus crisis and job shortage, but will allow some workers. And today, concerns about DACA, about decisions going to be made by the Supreme Court in June and how this will negatively impact those who are providing care to others. This chilling effect is holding some people back from going and getting the care that they need. Next, please.
Olivia, we have a question from one panelist before we go into the tools. And the question is, how does research explain high levels of asthma, HIV, and obesity rates for African Americans and Latino population?
So let me see. Okay, so if I'm trying to find the question here, high rates of, I see.
High levels of asthma, yes. HIV, yes. And obesity.
Yes, thank you so much. If you take a look at asthma, HIV, and obesity, you divide up the rates, the information, the data that's available, you divide it up by other socioeconomic status markers, such as poverty or education. You see a clear trend, and that is lower socioeconomic status tends to have higher rates of these conditions. So that's a common theme that you see throughout. Those with low socioeconomic status tend to have a higher burden in terms of chronic disease. And unfortunately, this pandemic, this virus has it is disproportionately impacting those who have these underlying conditions. So I'll be happy to also share some additional resources later on about this issue. Did you want me to answer the other question at this time?
I think we can move forward, Olivia, because we can answer questions at the end when people, if people want to spend over 1 hour, we can stay a little longer for a question.
Okay, great.
Yep.
So a few years ago, one of the things we did, this was actually in spring of 2017 in Pittsburgh, Pennsylvania, we convened a group of patient-centered outcomes researchers, health professional educators, as well as patients living with chronic pain. And we asked them, what do we need to do? What do we need to share with health professionals so they could be better trained, better prepared to work with patients living with chronic pain? And I think there were some excellent pieces of wisdom that were shared at that time. And so that's what this graphic is about here. We need to balance plain English without dumbing it down. We are seeing materials that are available in Spanish, for instance, but they're written at extremely high literacy levels. And so I think that makes it very challenging for people to navigate. Also, they're very dense. It's literally huge paragraphs, very dense. It's not broken up with graphics. And for anybody trying to figure out what's the bottom line, it's hard to synthesize that. It's overwhelming. We need to eliminate barriers to participation. We need to recognize that the patient is a whole person, and we need to treat the whole person. And at all possible to involve the spouse or partner in discussions about what you can do going forward. Take them at the word. Be welcoming. Recognize that individuals are not a number, okay? And they're more than just what their diagnosis is. Next, please. In summary, Latinos are more likely to get COVID-19, and they're also, because of their underlying conditions, are at greater risk of developing complications. That there's an interrelatedness of health issues to other problems, such as socioeconomic status and employment. Many Latinos have these underlying conditions, as I mentioned, that are not well controlled, puts them at higher risk of that severe illness. And there are long-standing recommendations to improve access and quality care that need to be implemented. Thank you very much. I look forward to listening to Ana Maria, and we'll see if there are any other questions that pop up.
Thank you, Olivia. That was wonderful. You really painted a broad picture of what is happening at a systemic level. And now we're going to turn to have a dialogue with Dr. Ana Maria Izquierdo, who is the Executive Director for Care for Your Health. And I want to introduce Dr. Izquierdo is a trained internist and geriatrician and has extensive experience training and supporting healthcare technology and quality improvement projects. She has previously held positions as a hospitalist with Johns Hopkins Medicine, Kaiser Permanente, and she also has been a medical director for a community center in Washington, D.C. Dr. Izquierdo holds an MD from the School of Medicine at the Universitat de Barcelona and a PhD in medicine from the School of Medicine, Universitat Autònoma de Barcelona. She is well-cited and published researcher and has completed postgraduate training in Franklin Square Hospital Center in Maryland, as well as the University of Maryland Medical System. Dr. Izquierdo currently supports Franklin Square research curriculum and has developed evidence-based introduction to principles of quality improvement. It is with great pleasure that I invite Dr. Izquierdo to have this dialogue with us today. So Dr. Carter-Pokras painted the broad picture and all of these conditions that make Latinos more vulnerable to COVID-19. Now we want to turn into what happens at an individual level. But before we go into that, Dr. Izquierdo, tell us about Care for Your Health. How long have you been in business, and what's the population that Care for Your Health serves? You're muted.
So we started.
You're muted again.
Someone is muting me.
You're good. You're good.
We started Care for Your Health in 2008. So it's been 12 years now. And the idea to provide multicultural care, particularly to elders in our community. And our goal is to assist people to age in place, stay home as long as there's a home, and support them as they go through their life changes and finally, hopefully, enhance their enjoyment in life. And what we do to do that, we have established a traditional geriatric practice in the community. Mm-hmm. We also go to people's homes when they're no longer able to leave home effectively. This crisis has been phenomenally challenging for all healthcare providers, but trying to figure out how to support all these community members that were already hanging by a little thread during this crisis has been, as I said, phenomenally challenging. And a little bit what we were saying, right? How do we provide information that is useful and not only in Spanish. I think this sort of lack of useful, positive information happens in any language. Actually, Dr. Olivia brought to my attention the lack of positive messaging that was available for the elders in our community. Everything was like, stay at home and hope everybody does what they're supposed to do or you'll die. So we've been working a lot on producing these messages that are informative and that are optimistic and can help people move forward during this crisis.
You created videos in Spanish for Latino families to understand COVID early on. I know those videos circulated on YouTube and went viral, and many people used them. They were not only used nationally, but internationally, because I know people from overseas also used the positive tone that you had to addressing the COVID-19, where it's from every angle, it's just frightening. You were saying, we can do this, and this is how we do it. You also do telehealth as needed as well with families that need that. So if we can go to the next slide, Besa, please. So have you seen Latino families who are experiencing the effects of COVID-19?
Yes, a lot. So I have to tell you, the majority of patients we have seen that suffer COVID have acquired it through work or by being in the same household of someone that acquired it through work. So essential personnel have been disproportionately affected, obviously, but these are people that did not really have a choice of whether to stay home and go to work. They had to go to work. I have heard of people going to work sick because they were the only breadwinner in that family. So there you go sick, you don't have a lot of PPEs because, they're not there demanding PPEs or I won't come to work. And then they get sick, they get the family sick, the family ends up very sick or dying. I have also, this was not a patient of mine, but I have heard in the community, people staying home because they're concerned about what Olivia was saying, that immigration impact, right? Particularly since the changes in the White House, there have been a lot of challenges for immigrants. And if you have ever requested, support with food or have ever qualified for Medicaid, and just remember that people who qualify for Medicaid have to have a legal status. It's not that easy, right? So they may be put at the end of the line to get a permanent legal status. So I have seen a lot of people not going to the right level of care to get care because of those elements. And we have seen uninsured people. One of the challenges in our community is that you really need an order from the doctor, and it's not just a paper order. The doctor or someone in their staff needs to get in the CRISP website to place an order. Then the CRISP website sends an email to the patient so that they can make the appointment. Well, what happens if you don't have emails? What happens if you're not literate and don't know how to read, so you cannot have an email account? What happens? So we've been making appointments and getting their emails and calling the patients and making appointments for them. So it's not that easy when you say, oh, there's an increase in tests. An increase in tests doesn't make it any easier to get a test. And you need to have certain resources in place. You need to have transportation to go to the testing environment. Right? I have had people that have foregone testing because they did not have a way to get there. Okay, so you coughing, good luck getting an Uber or a cab to take you, right? So the challenges that everybody experienced seem to be duplicate in this community we serve.
Right, also the cost of the testing, and if they have to sign up in a website, the likelihood of the community being able to do that. Usually the website won't be in Spanish. and so forth. All the problems that were problems before are accentuated, except in this case, I feel that if Latinos are not seen as a population that needs to heal from this virus, that needs to get help from this virus, the virus won't go away. So it is creating also a situation where those recommendations that Olivia mentioned that go back to 1993 or the 80s, someone needs to wake up. One pandemic like this, it's an equalizer, whereas if you are neglecting the Latino population, the virus won't go away because we will keep it alive, passing it from one another. So it has to go away for everybody. So as I say that, I want to talk about the cases that you have seen, Ana Maria, because you say they need a primary physician, and usually people in our communities don't have a primary physician or go to a community clinic and they don't know what's going to happen with that community clinic right now. So it's everybody's disoriented, and I know the county has been trying to put a lot of information in Spanish and has been trying to provide guidance. But what has been your experience at the patient level?
So the patients I have been seeing, we started a partnership with CRISP. So when someone called CRISP, which is the Regional Information Sharing, asking for tests, they would, and they would ask, no, go to your doctor. If the person said, no, I don't have a doctor, then they would connect them with us and we would do all that for them. So a chunk, and this is very, for me, it goes to what Olivia said. We've been talking about this for years. And we talk it for a while, a big explosion happens, we talk, and then we seem to forget about it. Now there's a pandemic, we'll talk about it for a while, and then we'll forget about it. But the same things, right? People cannot go back to work because the boss told them, you know, you cannot come back to work without a letter from your doctor. Well, I don't have access to a doctor. How can I, how can I go back to work if I don't have access to a doctor? Or, for instance, some organizations have sick leave. Well, you need a letter from a doctor. I had a patient that came to me with a positive test. He knew he had a positive test, but he could not explain to his doctor the kind of letter he needed so that he could get paid sick leave. So if you think about the challenges you experience when you try to get resources, multiply that by 10, and you will get a sense of what this community is going.
Yep. So the next question is, and we have been talking about this, the factors that affect the community, making it more vulnerable, that usually in many cases they are hourly paid and they may not even have sick leave that they can claim, or they are in a household, 3 people that used to have jobs have lost their jobs, and the one person that is working may be an essential employee and may be contracting the virus, as you said, Ana Maria. All of them are contracting it at work and then come back. So all of these situations. So testing and isolation become an issue. And I know the county has been working on this. And Olivia, you mentioned there's a testing center in Wheaton, and I know there's another one opened in Gaithersburg now. Now, transportation remains an issue that we have been mentioning. How do you get to those testings? And I don't have an answer for that right now. The isolation portion, I know the county is working at creating hotel accommodations for those families where a positive COVID person will be able to go for 2 weeks. We hope that those accommodations also have language capabilities, and all the instructions on what to do need to be in Spanish, because what we have found, and this is coming from a conversation we had, Ana Maria, is people get their result of their test, they are positive, and now what?
And now
right? What do I do?
And you know, you need to understand that the big hospitals, what they're trying to do is diagnose people and make space for others. That's their job, right? So that they can take care. So I get patients that come to me and they have gotten care. They just didn't understand a word of the care they got. So they call me and they say, I'm feeling lousy, I'm feeling terrible, and I don't know what to do. I'm like, so what prescriptions did you get? Nothing. So what did they tell you? I don't know. Okay, so not only the care, and now it's very interesting. This morning, I saw patients before we started this conversation. 2 of the patients are returning patients because they've been sick for more than 2 weeks. So they don't know that they can be sick because the communication going out is in 2 weeks, if you're okay, you're okay. So they're like, oh, it's 2 weeks. So now we have to put out that information like, in 2 weeks, if you're not infected, you're okay, but you can be sick for longer. This is a serious disease that can make you sick for longer, right? So then the conversation is, how do I go back to work? So all these things that we need a constant stream of communication that is not there. And let me say something about isolation. We want people isolation, but isolation kills too. You know, in our elder patients, let me share a case. I have a gentleman that lives at home alone. He doesn't have family. He doesn't have an next of kin. He doesn't have a healthcare agent, okay? The last time he was in the hospital hired detectives and they found a child somewhere in California that is not involved, right? So I went to see him in my monthly home visit. And he was like, I'm hungry, I'm hungry, I'm hungry. This gentleman has dementia and he's had death. So he cannot hear things over the phone. And he doesn't remember much. And I'm like, but I had talked to your caseworker in Adult Protective Services, and she told me you were getting food. Well, I'm not getting it. I'm hungry, I'm hungry. So we are talking, and I'm trying to figure out how to help him. The gentleman, the volunteer from Meals on Wheels walks in and leaves the food. I'm like, okay, so you are getting food. I get up to warm the food for him so that he can eat before I leave. And I found the previous day's food in the microwave. He forgot because of his disease that he had. So when we try to put him to get guardianship so we can keep him safe, because no aid can come during the pandemic, he has lost the ability to get an aid to help him at least eat once a day, the courts are closed, so we cannot process a guardianship. So these people, when I say that these people that are frail are hanging, you know, you push them a little bit more through this COVID pandemic and everything breaks apart, right? And this is not only a Latino thing, this is frail elders from all kinds of backgrounds. But those who have more support, more that know how to access care, have an easier time of doing this, right? So how do you access support in these cases? And people that were
Ana Maria, we lost you for a second.
already struggling, I think that people are responsible, not necessarily because of the COVID. Other things will kill them too because of the situation where we are.
The other thing that you and I were talking about, Ana Maria, is grandparents. And, you know, there's this advice that they should not be with the grandchildren, as Olivia mentioned, and the anxiety that provokes to grandparents, and some of the strategies that you have been mentioning about trying to find, talk to each other on WhatsApp, on the camera, or try to play a game. Do you want to speak to that?
Yeah, so there's a lot of grandparents that are the main caregiver of young kids, particularly the kids that don't go to school. And, you know, there's a lot of stress around, both for kids and the grandparents. It's not only the elder that is struggling with the absence of their grandchildren. You know, you have 2-3-year-old kids that don't understand why the main person in their life is suddenly no longer in their life, right? And how do you explain this? And we've been finding ourselves having a lot of these conversations. Okay, do you know how to use WhatsApp? Why don't you click this button here so you can chat with your grandchild in person? Why don't you schedule some time to play? What's your grandchild's favorite thing to play? Okay, you can play over an electronic format, and they just, it's not something they've done. It's not like us that, read our books in a Kindle or have an iPad,
Right.
watch a movie. These people have never accessed technology before. Forget the language issue. They have never accessed technology before. So when you say, okay, you can schedule a play date with your grandchild, they look at you like, what are you talking about, right? So as we support people, we find ourselves spending a lot of this time trying to avoid isolation, because any of you that know anything about geriatrics, isolation kills, no question about it.
Right. And
how do we convert distancing into distancing and not loneliness? How do we make sure that step between distancing and loneliness is not crossed? Is a very important part of how we fight this pandemic for our elders.
Right, and we have sort of 5 more minutes left, and we need to connect all of these to advanced care planning, because in this environment, there is an increased need for advanced care planning. There was an article in the New York Times on April 24th, and the president and CEO of the National Hospice and Palliative Care Organization, Ido Benak, said that this is a conversation everybody should be having with their loved ones right now. And the statistics say that from 1/3 to 2/3 of people, which is more than half, have not had an advanced care planning conversation with their loved ones. I am assuming that if you analyze this data by race, it might be even bigger than 0.5% that have not had this conversation. So what he said, he gave this advice because he says, if you don't let the system know your wishes, the system is going to take over. And we don't want that happening. So he said, take your cell phone and do a selfie video and say, this is who I am, this is what I want, and that would be enough to make your wishes known. So I want to bring that to the table and talk to you, Ana Maria, about this idea.
So I honestly think that is not feasible with the community we serve. So I actually worked with a volunteer of us last night, and we ran a report of all our, advanced directives, and we have advanced directives for about 95% of the people we see at home, and about 50-something for the people we see in the office. So we do talk about this. My experience with this is that people don't see this as my personal wish. If conversations have happened in the family, they have been after personal experience. The majority of people that I had this conversation or started, that have an idea because they have had a bad experience with a parent or an aunt or someone, right? Or dialysis, no, I hate dialysis, don't do dialysis. Or why? Because my aunt had dialysis and she hated every moment of it, right? So I think when you try to have these conversations, trying to figure out that piece of what's your personal experience that makes it important to say. And then I generally find that a lot of the advanced directives are just too difficult to understand for this community. Do you want CPR? Do you want, they have no context for those kinds of decisions. So the way I do it and I reach out to people is I tell them, okay, think the thing in your life that is more meaningful, the thing that you love doing, the thing that you cannot imagine your life without, okay? And then have this conversation with your family. The day I cannot do this thing that gives meaning to my life, whatever it is, I tell them I love reading. The day I cannot read or hear a book, I don't want you to take me to the hospital. That's the example I give them, right? So you go ahead and think about these things that are so important in your life and tell your loved ones that the day that you cannot do those important things in your life, what things don't you want to happen, right? So I don't want to go to the hospital, or I don't want to be intubated, or I don't want, I just want to stay home and I don't want to leave my home once that happens. Whatever it is, that's the kind of conversation you need to have. Because if you try to have an advanced care planning, like, go into your website and upload your healthcare agent, that's not going to happen with this community. It's not going to happen.
So advanced care planning for the Latino community is very different from it is for other cultures. And what we are saying is a electronic form that you need to complete online won't work. Nobody would do it. And these conversations are hard to happen. And when I had it with my parents, the immediate response was, am I dying?
That's the first question for me. What are you asking me? Am I dying? That's the first.
Exactly. So it is a long process. And for the audience today, there's many clinicians that are struggling with these conversations. These are not conversations. This is a big, big topic that's worth a whole other webinar for us. We were trying to connect it today because of the immediate need to know the wishes of everybody who's dying with COVID-19. But by no means this is something we can do overnight, especially because the forms, as Olivia was mentioning, we need low literacy levels. The advanced care planning forms are far from low literacy. Anything. I completed my MOLS with Ana Maria in a training that we did, and if it hadn't been for her help, I wouldn't have been able to complete anything or know anything about that form. And I have 2 master's degrees and have been working here for many, many years.
And can I say something? One of the things that I have found most helpful when approaching this subject with Latinos is to tell them, this is your gift to your loved ones. This is a hard conversation for you to have, but this is your gift. So when you get sick, your family will not have to shoulder a decision that may lead to your death, because they will know your wishes, and instead of making a decision that may lead to your death, they will be honoring your wishes. So they will be, honoring who you are as a person as opposed to killing you. So what you're doing by putting this in paper, but having these conversations with them, is really giving them a gift.
Exactly, and we have from the audience, Catalina, you're saying that the Cancer Center, you try to navigate advanced directive with the navigator, and hopefully you're talking about a language competent navigator, and we're very glad that that's happening. In the past, we tried to conduct some advanced care planning webinars and education, and I personally like the 5 wishes, which is 5 deseos, because it's a very gentle format. The other advanced care planning tools are so complicated, and they don't provide room for the kind of conversation that people need to have preceding these very tough decisions for themselves and for their loved ones. And we are right on top of the hour. Here is one. We have our final question, and I think what we are saying is, where we start this conversation is as early as you can, because but it's a hard conversation. If you are going to have to talk to your parents or your loved ones, the immediate reaction of older generations is there anything wrong with me? That would be the only point where I should consider this conversation. Before, it's kind of not luck or something like that. And I see Ana Maria nodding to that. How can we improve the advanced care planning conversations with Latinos and Hispanics?
Can I say, unfortunately, to serve these disenfranchised communities, and I think it's the same with low-income African Americans, the same for Latinos, the same for low literacy individuals, regardless of race. I think that you need to go the extra step. So, we have a Zoom meeting. They're not going to access it. We have something that they can look in a webinar. They're not going to access it. So where are they? Are they in their churches, how do I reach them there and actually have these conversations there? And how do I affect the decision makers in their life to have these conversations? Because unless we go the extra step, we will leave them behind.
Yep, yep. And I know there's some members of the audience that are offering participation in a death cafe, and we can talk about that offline. If you want to read the chat box here. But we are right hitting the end of our webinar. We want to be respectful of everybody's time. There's a couple of resources that we have. You know, Montgomery Hospice and Prince George's Hospice continue to provide services, and most of our patients are in their homes or in a nursing home or whatever they call assisted living facility or a nursing home, and we continue to serve them. So if you know someone who could use our services, please refer them to us. We also know that Care for Your Health has been helping Latinos who need a primary care physician, and we're going to send the website on our resources. And I know that Ana Maria is very generous, so if there's someone who could not afford the consult, she has a way to do. I think she's going to provide care regardless, for which I also think we should, if you have the ability to support a nonprofit that is doing such good work for the community, you may consider supporting Care for Your Health. We're going to send all of these resources out. On the Prince George's Hospice side, we have a Faith and Comfort Corner, and we have the image of that on your screen. The grief that COVID-19 is provoking in all of us is tremendous. We are grieving things we used to do. Some of us are losing loved ones and not able to go to the hospital or to go to the funeral. So we are trying to provide resources for our community, and we will be starting a series next week for frontline workers on conversations on grief. So feel free to sign up for that, and we're going to send those resources out. I also want to let you know that the county has a line. If some of you are providers and you have someone who in need of some more guidance regarding testing or isolation or all the things that were discussed, the county has services, and there's a phone line that you can call. We will send this on the resources as well, but the phone line is 240-777-1755. And that can be used, and I know they have language competency there as well. Unless there are more questions, I know there was one question earlier on about the Cuban community, but we can send that offline to Dr. Olivia Carter-Pokras, and maybe we can respond to that later. It was regarding the Cuban immigration as the new wave of Cubans. That may require some research, unless, Olivia, you have an answer for something like that right now.
I was trying to stay on top of the comments, and I've already sent some resources in response to the questions, but I didn't see the one about Cubans. So
we can talk about them offline. We are already 7 minutes over. Unless there's another burning question in the audience. Well, the question is there a difference between the old Cuban immigration as well as the new wave not doing so well of Cubans, if I'm understanding this correctly?
Right, all right. Well, the old wave of Cubans tended to be a higher socioeconomic status, and so they were better educated, and perhaps they were better able to make that transition into the United States. Then the newer wave tended to be lower socioeconomic status, not as well as educated. And so there was a real difference in terms of how prepared they were to integrate into the United States. I can work with, I actually served on a doctoral dissertation committee with a student who did very detailed interviews with Cubans in Miami. And so I can reach out to her and see if she has anything specific that she can add to the discussion. But that was my understanding, a big difference in the waves that came out and how prepared they were to integrate into the United States. Socioeconomic status played an important role.
Perfect. Thank you. I want to thank Olivia and Ana Maria. It's been a joy, and I hope the audience has gotten some tools and good information. This is by no means the last webinar that we do. I'm going to ask you to continue this as we learn more and this pandemic continues to affect our communities. We will continue to find ways to share knowledge that can be helpful in doing something about the situation that is so extreme for our communities right now. I'm going to turn it to Besa.
Thank you, Monica, and thank you all. I'm always learning with our participants, and this was just rich and just full of so much great information. I do want to be respectful of your time. I know we're a little over our expected end of time, but I think this conversation just was worth a while. So if you can just take a moment to complete an evaluation form. I'm sharing the link to the evaluation right now. Please click on it. It shouldn't take you more than a minute. We really value your feedbacks. They help us improve our program. This program is, as Monica mentioned, is also part of a series. So the last one of this series would be next week, and we're going to be covering the Asian American community and how they're dealing with the COVID-19. So stay tuned for dates, and registration would open at the end of this week. So I'll be emailing all of you that. Anything that's shared, as I said at the beginning of the program, would be shared with you in the follow-up email. This program does count as an elective towards the certificate in in-depth life care program, and Magna is sharing the link to that information right now. So I want to thank you all for joining us, and we'll see you soon. Thank you, everyone.
One last thing. We had the first series, the first program on the series of COVID-19 is how it's affecting the African American community. And if you in the audience would like to have access to the recording, all of these programs are recorded. And the recordings are shared with you. And if you feel like you want to share them with somebody else, please go ahead. So maybe we can send a recording of the African American dialogue as well. I was just thinking about that. Thank you, everybody. Thank you so much.
Thank you, Monica. Yes, so as Monica said, we actually have a very robust YouTube channel with over right now 20 educational programs. So we are making all of these available on our YouTube, on our website. So the first of the series is up on our YouTube channel, but I'll also share it in our follow-up. So thanks, Monica. And thank you, everyone. Enjoy the rest of your day.